Today will be informed consent just based on elements and sort of waiving. The waiving and delegating we're only going to touch on because I think we're going to cover that more in depth than we do end-of-life issues and such. I didn't want to press it too far today, but it needed to be mentioned at the very least. And then on next Tuesday, I think it is, we're going to do something in regards to the ethical and legal aspects of consent, okay? I know it's obvious, but let's say it. It's much easier to talk about how we ask for and receive and evaluate consent when we're doing it in some sort of an analytical situation than if we're in the moment, okay? I understand that. So a lot of this, like most things that we learn, are easier done in principle than they are in actual action. But we need the experience, and where we don't have the experience, we need the knowledge behind it. Also, as I already mentioned, bioethicists are not always going to agree on the best course of action. There's debates all the time. That's why people publish articles, and you see people taking actual sides on very controversial and serious cases. So, you know, one of the fallacies is you can't just appeal to authority just because a person says, well, I'm a bioethicist, what's your argument, you know, and then what's the argument against this, and then how do you sit? It could be that we don't understand the circumstances the same way, or it could be we're not actually have access to particular circumstances. About 3 or 4 years ago, maybe a little longer, there was a case in Texas, I don't know if anybody remembers, where a woman was being kept alive by life support, but she was pregnant. And they were trying to determine whether or not she was, at one point she was about 15 weeks. It went to a court, and by the time the court hearing was over, and they could have, and they said that if you want to undo her life support, and therefore both her and the fetal life would perish, at that point she was already about 20 to 21 weeks. So it was getting close just because of the subsequent court hearings that this child would be viable. Okay, so we're not here to argue that case, but I can tell you bioethicists were on all sides of the spectrum on that, all right? So it isn't that this is subjective. I don't mean to say that. I just mean that there's different perspectives. And I can almost assure you that your concept of personhood is going to be the thing that determines where you go on that, which is why we spent at least 1 or 2 classes on that. Okay, how much information is necessary for a person to have and offer consent? I mean, at what point do you call it? I mean, we need to be informed. We're going to talk about that as one of the elements of consent, but how much information do you need? You know, again, this is something that we're going to have to play out. We can give percentages. Percentages may not just be simple, like it's, 50-50 chance for this. I mean, there could be other complications. What's the percentage of complications? Once I get the complications, what may come from that? How will that affect my quality of life here on out? Well, we only know for the next 2 years. Well, how about, I mean, in other words, there's no perfect scenario where you're going to have all of the absolute information. And even if you could have all, that the person then would feel comfortable in saying, well, okay, now it's adequate, I'll have consent. So there's bare minimum that a person's going to need, and we'll talk about that when we talk about the 5 elements as they're listed in your text. But we also have to just be aware that at some point we are asking for moral certainty. There's no absolute here. That we could say that at this point the person has now enough information to consent. Also, too, there's always going to be the issue that we have our own moral stances. And those moral stances may conflict with what this patient is consenting or denying. And that's difficult, right? We think it's worth doing something. They don't. A nurse is going to be an advocate for the patient. The patient has autonomy. Well, so at what point do we no longer insist, or not, I shouldn't use the word insist. Just being a medical professional, you are well aware, if you've had any issues yourself physically, when you're at the doctor's, you wait for every phone call where they're saying, the doctor's talking to you, you're reading facial expressions, is there something I can read into this? So there's a sense of power there, right? You don't want to use that sense of power over the individual, and therefore to dismantle their consent a little bit just by the fact that you're going to throw your authority at them. Like, I know about this. Now, if you have experiences, you should share that. That's going to be part of the consent and part of the information they should have. I could tell you what's happened in the past. I have a personal story you might share, okay? but just so you're always clear at the end, and you should be clear by saying it. I remember when my father was in the hospital, the one doctor, even when he was saying you do this, this, and this, he said, I want to be extremely clear with you. It is your decision, and we will honor your decision. You know, so sometimes saying that, even if you can say, I believe this is the best course of method or treatment, but in the end, you know, I'll respect your autonomy. So nonetheless, especially for some of us to think that maybe a little heroic measures might be warranted from time to time. A student in the previous class had said that that was the case with her mother, and things worked out well because of it. Actually, she kind of thinks they went against her mother's wishes, per se, but in the end it worked out, right? So everybody's glad from it now, but she wasn't so sure, says she. In an emergency, what do you do, right? If you can't assess consent, then you have to accept it as implicit. So it isn't that consent goes out the window with an emergency, it's just that in an emergency, the same steps are not going to be taken. And the scenario that you're going to work through in class today with the poll to texting will be a young man who got in a motorcycle accident and they're not quite sure what to do here. So unless you can be absolutely certain, and there's an advocate or a proxy or something, you're just going to have to accept the consent as implicit and leave it at that. But nonetheless, if they're unconscious, the same thing applies. If they are not conscious to give consent, then you cannot assess it. So, again, unless there's an advocate, a proxy, or somebody with a durable medical power of attorney that can speak for that individual, then you're going to have to just treat consent as implicit. Again, unless consciousness has occurred because of a pathology that you saw coming, and we've had plenty of discussions about this in the past, and okay, but it all depends on the circumstances, all right? If the patient comes in unconscious, then we're in another emergency situation.
So if there was like an emergency situation and the patient really couldn't get consent, like they were unconscious or something, and you like did a procedure and then they ended up dying during that, and then a family member comes and like gets mad at you, I mean, it wouldn't be the nurse's fault.
Yeah, no, you'd be perfectly fine morally and legally. No. No, because consent's going to have to be implied, and if there was, in other words, without the person's explicit consent, you're going to have to accept that life-saving treatment is necessary. There's nothing without risk. So if the patient does perish, unless there's, let's just assume there's no negligence involved.
Yeah.
So if it was just a mishap, not even an error, I mean, just the fact there was a risky surgery and the person didn't make it, and then the father comes in and says, you know, they would never give the consent. Well, but you would never have known that. So ethically, you know, here we're talking moral certainty. It's what do I know now, right?
Is that like the Good Samaritan law? Like if you see someone like on the side of the street, like passed out, and you try and go help them, but then they
Yes,
die, like,
and I guess it might differ depending on particular states, but if you're trained, you know, then there's different criteria for you than just somebody's walking along the street. Somebody just walking along the street doesn't do it well. You know, they don't know. But if you're trained, you don't do it well. Different story, right? At least, but yeah, it's the same thing. So I guess then that brings us to the last part of this, is that there are exceptions. Nothing's ironclad. There are times when a person is conscious and it's not an emergency and they do not consent to treatment, that they still don't get their way. And tuberculosis would be one of them, right? I'm imagining, did anybody hear, they just named the coronavirus, they gave its actual name now. Did anybody hear it? I heard on the radio this morning. It's similar to that, but I'm sure the Corona Beer Company is probably grateful that they've gotten rid of that name for them. But I don't know, but I'm guessing that, you know, if a person was exposed to that and they, you know, or at least they'd have to go through screening, and until they're screening, you know, you don't get consent. I mean, there's other risk factors for a wider population, something like that. Did you hear the physician that first, I guess I'm going to say, discovered this, passed away? Did you hear that story? And he got in a lot of trouble because he was flagging people down on social media and everything, saying how serious this was. And the government really stamped on him, but he then contracted it himself and passed away. Okay, now I didn't do a lot with the legal issues here because it's unlikely that you're gonna have to flat out remember the court cases, right? But you have to know the gist of that. So the reality is that when we're talking about consent, that consent ultimately lies with the physician, not the nurse, or the hospital staff that's present, right? It's the assigned physician. So if the physician is exerting her or his competence, the nursing and staff cannot interfere. That's already been determined by court cases. Also, it's expected that the nursing staff carries out diligently whatever it is that the attending physician has asked. So you can have questions, but you need to carry it out. It's not going to bode well for you legally by you trying to override it. That being said, you know, there's always a but, right? And the only but we'd have to like really throw out here is if there was something that it was apparent they were going against established practice within that institution, protocol, or that you detected some negligence, or you detected some overriding on consent, at some point then, you know, you might be liable if you didn't speak up. It just depends, right? And I'm not a lawyer, and I just don't get in between these cases per se. What I do want to say about this is that it's very important for us to keep in mind that consent can be overridden quite easily by people who think they're doing what's best for the patient, all right? So the author of the text you're using, DeMarco, he has a personal story of a friend of his who, his physician, and this guy was friends with the physician, so it wasn't somebody who just went to the first time. The physician wanted him to do a PSA test, okay? So guys, as you get older, you know, prostate's always a concern. Now, the PSA test is a little controversial because it doesn't really, we don't know if it tells us what you want to tell us. In fact, it could just be a false positive. There's various reasons why a person's PSA levels could be high, not all for prostate cancer. And they don't do digital exams just per se, physicians anymore. Typically now a urologist will do those. So it used to be years ago that the physician, the GP would do the digital exam. So anyway, the man didn't consent to it, and he says, no, I'm not doing the PSA test. It's not worth it to me. What happened then is he started, like later on, getting some pains in his back and like his lower leg and such. So when he went back in for that, the GP starts to wonder, you know, could this be something else? So perhaps it's, you know, prostate cancer or such. So they do MRIs and they realize that there's no masses and this isn't that. But he goes back to the patient and he says, you know, I really like to do a PSA test. I know you were against it before. We're not doing it for diagnostic terms now. But we're trying to determine whether or not there's something else going on here. We're trying to figure out where these pains are coming from. So they did it, and the PSA came back a little elevated. So he brought the concerns up to the patient. Well, the patient at this point is like, okay, you're calling that a high level, but I had it done a decade ago, and it was higher back then than it is now. So the doctor said, well, I guess we're not going to be worried about it. But then the guy said, I know what you did. You knew that that had nothing to do with, it turned to be muscle pains. That's what the individual was experiencing, muscle strains. He goes, you knew that it wasn't that, but that was your way to sneak it in. The guy just kind of smiled. Did he consent to this? No. Was it, you know, drastic? No, it's not invasive, right? I mean, it's a simple test. But still, the man did not consent. So DeMarco's point is, and the reason why he stresses this, is that people often have to fight for consent. Because it's easy for physicians who, quite frankly, do know more, to not want to paternally, you know, push that on individuals and say, I think it's necessary for you to do this. So his point is that everybody has to be vigilant. So even if it's the physician itself who retains the ultimate authority, according to these two cases that I posted up there, to solicit consent, it's everybody's concern. Somebody at some point say, hey, come on, you know, really. Does that make sense? I have other stories, but I'll leave it for another time. Okay. Now, when a person does give informed consent, right, I've already stated that their informed consent can conflict with the values that we hold as to what individuals will do. We don't put away our own morality, right? I never liked this idea that I'm at work, so I can't bring my own personal beliefs and ideas of the own person to work. You know, politicians try that. It's not really good. But we also have to make sure that we're not, how do you want to say, imposing those on other people. So at some point, we have to make sure that, you know, even as a nurse, you can say, I really think this is good. The doctor, you're going to love him. I've seen people do this before. They're perfectly fine. All that can be discussed, but in the end, that individual has to know that it's entirely up to them and them alone. Which brings us to this other point on whether or not we would discern the individual's decision as being rational. So sometimes people will deny particular healthcare procedures, and it doesn't seem right to us. In other words, you might be thinking to yourself, do you not understand what I just said? You know, we don't know all the circumstances, and it's very difficult for us to get to the bottom of it. Oh, and here's an example. So I have a friend, now he's a physicist, so this isn't somebody who's unintellectual. And he's in his mid-50s, and he's in very good health. Thin, small, you picture him at a distance from her, okay? Just eats, I don't want to say eats as poorly as he possibly can. Deep fry everything. I mean, the doctor says you gotta stop eating fatty food, not eating fatty foods and deep frying everything. Now, you start having a conversation, you're gonna start thinking, this is an irrational decision, right? But remember, just with like anything with cultural sensitivity, what we have to do first is not judge. What is it that we have not got to the bottom of here yet? You know, this person looks otherwise like they can make decisions for themselves. Why are they not getting that you can't just simply eat like that? You could come out right and say, but if you don't change your diet, you're going to develop some very serious cardiac disease, perhaps, you know, stroke, cancer, and not live a long life. You could say that, that's probably true. But if you said that to him, he'd say, that's exactly what I want. You don't want to live long? I absolutely do not. Now you're starting to think, what's he have, a death wish? He goes, I don't want to make it into my 70s. You don't want to make it into your 70s. That's not like a rational thing. Okay? So again, just put away all the prejudging. Just keep asking questions, because you know, DeMarco's point, there's something here. We just haven't gotten to figure out what this individual is. If you keep asking him a few more questions, what you're going to find out is that his mom and dad both developed severe dementia by the time they were in the mid to late 60s, certainly in their 70s. And both his grandparents, on both his mother and father and his both paternal and maternal grandparents, all of them developed the same type of dementia. His uncles have developed this dementia. Does he know he's going to get it? Well, nobody knows he's going to get it. But do you see, he doesn't want to go through what they went through. He doesn't see any problem with living a good, full, robust life and having a cardiac arrest before he hits 65 or 70 and suffers probably the same fate that his parents and grandparents felt. Is that irrational? Probably not. It seemed it up front, right? My point here is that just because a person seems irrational doesn't mean that they're not getting proper consent. They might be very certain as to what they're doing. So if somebody were to have the diagnostic test and find out that they had such a high propensity for breast cancer, you see some people get radical double mastectomies, right? So I knew somebody back in the early 80s, late 70s, this is before any diagnostic tests were out. Her mother died of breast cancer, both her sisters died of breast cancer. She was 31 years old when had a double radical mastectomy. Is that irrational? I mean, it could be that now we have the test, she gets it. I mean, to be honest, I haven't followed up. I haven't seen her in 4 years. Maybe she never would have gotten it anyway. But is that irrational? No. I mean, okay, that's a radical thing to do for somebody to have a double mastectomy, but it's certainly not as radical as wanting to live. So what seems irrational back then, just even today with new information, is not as irrational. So my friend who does not want to wind up with dementia to the level that his parents and grandparents had, all of a sudden now it doesn't seem like a half bad idea. So yeah, the only point I'm trying to make is really basic. Let's not assume that because what we hear as far as a lack of consent or consent seems irrational, that the person is not giving consent because of lack of sound mind. Those two things don't go together. That kind of makes sense? All right. The last thing here is that healthcare is a process, right? We're always looking at case scenarios in this course, and we're going to be looking at snapshots. But life is not snapshots, and healthcare is not snapshots. Healthcare is ongoing treatment, and circumstances change. And as circumstances change, previous consent might have to be visited, and previous lack of consent might have to be revisited. So a particular operation that has a 50-50 chance might be not great odds, until all of a sudden there's another circumstance involved that if you don't do this because some complication has occurred, that all of a sudden now you have 3 to 4 weeks to live unless you do this operation with 50-50 chance. Okay, so you may not have consented to the 50-50 chance when that was it, but now if you're only looking at 3 to 4 weeks to live, but a 50-50 chance of making it through an operation that will give you life outside of that, the whole thing changes. So we can't, and of course no medical professional would assume that consent stays static like this, but we also have to realize that, health is very dynamic. And there's a lot of factors that come into play. And those factors, as we see when we go through the elements, are going to constantly be changing. So it's nice for us to take a very simple scenario so that we understand it when we work through a case study, but we're looking at a snapshot. Healthcare is something that, well, let me put it this way. My general practitioner, I really love the woman. I just think she's just really good. We're on the same page, right? She's after a good life. We want people to have a good life. So what does that mean for you? I mean, I get to choose that, right? So I can choose what I will take or not take as treatments. And what is perfectly fine for me taking as a treatment or a medication, I have friends who won't get near that in a million years. I have one friend he's an ex-Green Beret, and he's got all kinds of issues going on, you name it. And he was on every medication you could possibly imagine. Well, he's 50 years old and retired at that point. He's on a holistic keto diet, went off all medication. I don't know what the long term is going to be for that. Diets come and go. We find out good things and bad things. But he's informed. I mean, this is what he does since he's a he's a 54-year-old with young children. I think he's like a 3-year-old and an 8-year-old, and his children later in life. So this is all he does. Him and his wife are both stay-home parents, and he spends most of his time, making bone marrow soup and collecting honey from bees in his backyard, because he has it in his head that this is going to give him good health. But he went off all his meds against his doctor's wishes, but the doctor's like, it's fine, it's your life. I mean, you get to choose those things. And what if he's right? We rely quite a bit on scans and everything else, and they, and everybody swears by them. So healthcare is a process, and throughout our entire, even if it's a particular pathology you're being treated for, circumstances change, and within the circumstances, those changes also include changes in consent, all right? Now, I'm not going to go through these in depth because these are all listed in your text, but I do want to just give a little bit of a shout out about each of them. Is there any questions, by the way, on the first section? You can always email and text me too. People do, so don't feel like you can't. All right. I had a student who was a math genius, and she went on to become a statistician. When I saw her a year or two ago, I said, what are you doing now? She goes, I do statistics for the medical field. I said, specifically what? She goes, I determine percentages of likelihood for longevity on what cancer you have. God love her. I could not do that job. I mean, it would be depressing every day going in, this and that. You have 30% here, 40% here, right? Here's my point. This is a touch and go thing. When people have a prognosis, you don't want to be unrealistic. And you also don't want to deflate them. So how do you balance these two things, right? Without being a consequentialist, unless you like that, right? So my mother-in-law was diagnosed with lung cancer, stage 4, I think, right? They don't always like, some oncologists, my friends and oncologists don't like putting stages to it, because then people immediately put themselves in categories. Everybody knows cancers are so distinct and different, it's hard to be that general, so you go with what they say, but nonetheless. So I think the way the doctor led it with her was, let's just start treatment, let's start chemo, we have a therapy for this, and let's see what happens, all right? After she survived a year and a half, confided in her and said, "We're very surprised and glad that you are still here. We never would have thought." Well, could you imagine if somebody, you weren't sure, and you said, look, our experience is that you let a year out, get your affairs in order. Some people cash it in right there. Now, this is science, so we're not saying that a person's, willpower is enough to carry them through, but we also know that sometimes it carries them through. We don't know the science behind all that. She's 8 years out now, right? She's doing scans every 6 to 12 months. The doctors are absolutely perplexed, right? You would not want to have told somebody in the beginning, we see you having a long life ahead of you. That's not fair. And you also don't want to do it the other direction, go home and get your affairs in order. I'm imagining the doctors would do everything they possibly could to not be pigeonholed. And just say, let's just see how things go. We're going to do this. We've had some success. Because the honest truth is you just don't know. Right? You really don't know. I have a friend, he's a Catholic priest. He's a genius and a wonderful man, the humblest person you ever want to meet. If he was here, you would never, first of all, he wouldn't say he's a priest, and he would never tell you his level of education. He has 3 PhDs and 4 master's degrees. The guy's that bright. He thought he had a respiratory illness. Turned out he had leukemia. And they gave him a 15% chance to live. Now, that's not real high. At one point, he was terminal. They just thought there's nothing else that can happen. But then there was some, experimental procedure that was coming up. It was available, and we're going to talk about this in the next slide or next bullet point or two. It was available to him in Baltimore. And he literally had to be in a tent, if you want to call it that. I think for 4 to 6 months. He wrote 2 books while he was in there. Today is about 7 years out. He's fine, but they're testing him regularly. It's not a likely prognosis, right? So if you even see commercials for the Cancer Institute of America, people that were diagnosed and they're living at the bottom, it says this is not the expected outcome, right? They're not just putting a disclosure out there to save themselves legally and ethically, although they are, but they're also saying that we don't know. So nonetheless, you have to know the risk. There are risks to every single procedure. If a person takes statins, there's risk, right? Muscle pains. Some people claim that it could, but for some people it causes liver issues. Others say that it elevates fasting glucose levels. My particular view, I get in arguments all the time about that, but we don't really know. It's their call. Everybody has to make a decision on the risk, but they just need to know the risk, right? So if you know anybody that wears CPAPs, you know sleep apnea, right? So if you wear a CPAP, it's just forced air to keep the air passages open so that you don't literally suffocate through the evening. That's not an invasive procedure. It's very uncomfortable. Some people don't like it. And some people are non-compliant. Right? They don't wear it. If you don't have moderate to severe, if you have what they call minor sleep apnea, it could be corrected with a surgical procedure. They can go in and they can open up the soft palate tissue. They can remove the tonsils or such. And it could be that you don't have to wear a CPAP again. Why don't people do it? Because it's a medical procedure. And there's a risk involved. There's no risk with putting a mask on. Because nothing's going to happen because of that. If you go in and do that, anything can happen. So people weigh that out. But that's perfectly fine for somebody to make that decision. But they need to know that, right? And by the way, it could even change if the elements change. Like, what if, they'll measure apnea by, episodes, like how many times you might have stopped breathing at any given time. And that's to determine if you're thinking minor, medium, or whatever they call low, medium, or high episodes. But if you're borderline, and they're like, look, you're going to have the operation, it only really reduces it by half, and you might not be out of the danger zone. So there's a chance that we'll go through this, and even you have to wear a CPAP afterwards. Not guaranteed, not likely, but there's a chance. You might start going, well, I don't know now, right? So it's just important for everybody to know the risk and just get the information. And again, let them make the decision, is this worth it, right? And what would be my benefits? So if a person's going to get an operation to carve out the soft palate of their throat so that they don't have to be on a CPAP machine, they want to know that that's going to be the benefit, right? In other words, you're in the category that if this works, you're fine. Okay, we know that. If a person's getting knee surgery, you know, what's gonna be my mobility? Like, how long is this gonna, how much pain will be involved? How long am I gonna be incapacitated, and then what will be the benefits afterwards? Most people that have knee surgery, you know, usually claim, I wish I'd have done this a decade earlier, right? Because they were hobbling around with bone on bone. You know people that have these problems and such, I mean, it's painful, right? And do you do them both at the same time so you get it all over with? Same thing with carpal tunnel, right? People with carpal tunnel are thinking, if I get them both done, man, you're gonna be laid up there and sitting watching TV like this. People are gonna be feeding you and doing everything else for you. Do you have the opportunity to do that? When you're done, will it work? What's the probability of this, right? Here's my story. You'll like this. I do a lot of physical stuff, not exercise. I used to, but I don't do that anymore, unfortunately. But I do a lot of physical work, and it's hard on the body, right? So, one summer, in a week and a half period, you can't make this up, I was mowing my property with a riding lawnmower, and a rock shot out, hit the shed, and hit my eye before I could even really do anything. Now, fortunately, it didn't hit my eyeball, it just hit like right below the brow. But you know, a sharp laceration bleeds profusely, right? This is going on, I tried to figure out when I went in the studio. I'm usually pretty calm. I mean, I could probably lose a limb and just walk around for a while and figure out where should I go. So I walk into the, you know, asking her, I said, look, in the first aid kit upstairs, there's some butterfly stitches, can you get me a few? Oh my God, what happened? I'm like, just relax, it'll be fine. So I just held it together and put the stitches on and stopped bleeding. Within 15 minutes, I'm not mowing again. She's calling me an idiot, right? So anyway, I get that done. Then I had to work on my house, so I started putting scaffolding up. So I was borrowing some boards from my neighbor. I have my own scaffolding. I'm up about 15 feet. And I'm up there putting other sections on, and the board broke, and I went straight down 15 feet through this, right? Busted up my one leg. Didn't break anything, but I was in some severe pain. But, you know, I only have X amount of time to get things done, and I've been working since I was in 9th grade, so this is no problem for me. I'll work wounded, right? So I get back up there. Now, it's a hot day, it's the middle of summer, I am fatigued, I've been working since 6 a.m., it's now 5:30 in the afternoon, I am shot, but I gotta get this done, it's supposed to rain tomorrow, right? So I'm up there, and I'm going to put the next section of scaffolding on. Somebody decided that some sections of the scaffolding could literally be 1 inch wider than another section. I never even thought of such a thing, right? I couldn't get the thing in. I am fatigued from holding this thing up at 15 feet, it probably weighs about 50-some pounds, and it fell down and smashed my hand between 2 pipes. So I still have my finger, right, like this. My finger went this way and out. So it was like, you know, I hold it like this, it was like pointing over there. My wife's like, you're going to urgent care. No, I'm not. I said, I don't have the time for this. I said, I know what they're going to do there. It's not a big deal. Don't even need popsicle sticks. My wife's like, are you some redneck? I'm like, just move away. So I went and I straightened it out, put popsicle sticks, and I wrapped tape around, and went right back to work. Perfectly fine this way. What I didn't realize was I tore ligaments. And ligaments, they don't grow back. Who knew it, right? That type of thing. But I wasn't going to go and sit in some, I know I was going to be low in the totem pole. And I'm not going to emergency room on a Saturday night with a broken pinky. Because, I mean, I'm going to be there for the next 9 hours. There's no way I was going to do it, right? So I can make, there was a point to that story. Right now I'm forgetting what it is. But nonetheless, I guess my whole point was that I can determine my own benefits. Even something small and simple like that, it's up to me. I'll weigh it all out. I'll say what I want to do. Here's a side story. You'll like this, especially daughters with your dad. I have 3 daughters. I'm on the front of my house is only a single-story range, so it's not high. Back's high, the front's not. And I got the ladder going across the shrubs. I get up there, must have had it too far out, it kicks out, I go down. Fell on the rocks. Took me 10 minutes to get off the ground, that's how bad it hurt. I finally get off the ground, I go in, my oldest daughter is the one who went home. I said, Nick, didn't you hear the ladder fall out there on the ground? You know, I thought I heard something, I thought it was a ladder, I wasn't sure. Did you guys do that to your dad? Don't even go out and check. He's out there on the ground, he's okay, he'll move, you know? All right, alternative treatments. So, like my friend who was the priest that went for the experimental treatment, that's perfectly fine. Not everybody has access to that, so we all know the justice behind some of this. Some people that don't have good insurance are not going to have access to those particular things. And you have to be in the right place at the right time for that particular oncologist to know that this has just come out and we'll try it, right? It's experimental and we're pretty sure it's going to work. So it has to be feasible and possible. It just can't be that it's, available somewhere in the world. At some point, there's proportionality that limits the treatments that we get. But an individual needs to know what alternatives are available to them, all right, that are feasible and possible. We can do this, we can do that, we can do this. So I had my cousin who had died at 50 from liver cancer, his one friend said, why don't you go to Sloan? Why don't you go to somewhere else? The guy, he was a wealthy individual. Why are you sticking with the local hospital? There's nothing wrong with the local hospital, right? But why don't you go? And he just felt comfortable. Probably should have at least got a second opinion on it, but he was quite comfortable, right? But he was being aware of his alternatives. That's the whole point. We're talking about consent here. If it sounds irrational, it wasn't irrational to him. He was very comfortable with the physician he had. Even though the physician said, you're the youngest cancer patient I've had, right? But nonetheless, and he did unfortunately perish at 50, but it was at least made aware to him. Okay, this is not alternative medicine. You have to stick within science. So somebody who says, like, when you can make fun, but when you get older, you're going to think the same thing. My mother, God love her, she gets in her 80s, she starts calling me, Stevie, do you see those things on TV, like you wear them like they're magnets? Do they work? No, Mom. Well, how do you know? Mom, they don't, they're magnets, Mom. They're not going to cure, you start thinking about this. See, no medical professional is going to encourage that, right? Here's a story. I had I had a student I happened, for whatever reason, was somewhere where his dad was there, and his dad came over and said, oh, my son was telling me about class. Hey, my wife's a physician. I said, no, I didn't know that. He never said anything. He goes, yeah. Now, he's Chinese, and you have to know that to get this story. So he goes, yeah. He goes, me and my wife, we yell at each other all the time, because she doesn't believe in acupuncture. And I said, well, that's because it's not a medical procedure. That's what she says. I said, I'm not here to get between you two, but it works. I said, it's not a question of it working, it's a question of it doesn't have clinical trials behind it, so a physician can get into legal issues if they're going to start treating this with acupuncture. Because my wife keeps calling it backwards, and she keeps touting how Western medicine is so far advanced. He goes, and then I explain to her that my form of medicine is 2,500 years old, how old is your form of medicine? And then she shuts up. Well, she probably doesn't want to get an argument, okay? Now, if a person is getting treated like that, and they find relief in it, the physician's not going to oppose that. But the physician's also not going to encourage it or consider it, right? I mean, you can go and say whatever you want. You can go and tell the physician that I'm wearing a magnet bracelet and it's working, okay, perfectly fine. Or the copper, I don't even know what those is. There's some of those copper knee braces and stuff. I'm not even sure what they're supposed to do. Are they just knee braces? Or the copper has something? I don't know. But a physician's not going to encourage that. But if somebody goes in and says it, they'll probably say, hey, if it works for you, glad to hear it, and leave it at that, okay? In the same way that a person has the right to consent to something, they have the right to deny treatment. So part of the consent is once I understand everything, and once, it's the disclosures, the risks, the benefits, and the alternative treatments that they're given to me, if I say, no, I'm good, then that's part of it, all right? But it has to be on full disclosure. There's all kinds of scenarios we can come up with tonight. Any questions on those? It's pretty straightforward. We're going to do this real quick, and then we're going to do some text to polling and call it a day. Okay, this plays off the last element, right? If a person has a right to consent based on their autonomy, and you as nurses to be advocates for them, then they also reserve the right to waive that consent and offer it to another person, okay? So, like for instance, if they say to their doctor, because they trust the physician, doctor, if you think it's best for me, I'm going to do it for you. As a matter of fact, I don't understand all of this what jumbo that you're telling me. It's too above my head. I trust you. We've been friends. You'll do what's best for me. The physician then will basically take over the attitude of consent for the patient. What I want you to be very clear about is that's not paternalism. That's not the doctor making decisions for the individual outside of their consent. Like I told you with that original story about the physician who wanted the PSA test on his patient. That's paternalism. If you go and tell your doctor, I trust you, do what you find is best, then, okay, fine. This can also fall on you as nurses, all right? Because not everything that's consent has to do with some operation or procedure. I'll give you, for instance, with my father-in-law. At some point, we knew that he was not going to be coming home from the hospital. Fortunately, but this was up at Wilkes-Barre General, he was in the ICU, and we weren't quite sure how long-term at one point, but they had an acute care unit, so there was an opportunity. A nursing home would not have sufficed, and he really wasn't proper for him to stay in the ICU. So that was an alternative, right? But at some point, you had a sense, just by talking to doctors, that this was the day. You know, it's unlikely he's going to make it through the next 24 hours. But his port was, a lot of times the ports that you're going to be taking care of, depending, like, you know, feces and such can come out, they can be very infected, and you just realize, the nurse was going to look at that and say, it's not good. So you know that sepsis is now, you know, you can see it in the wound, right? Or it's a detected, I should say, not see it. But they came over and they said, you know, he really should be cleaned. What would you like us to do? Okay, now, I was not going to get in the middle of that. You know, just being a son-in-law is not, I don't have enough clout there. If we would have been backed up a little bit, I would have said, just let it go. You know, because the likelihood of him living the next 4 to 6 hours is not much. There's no sense. You know, when you're at that level, the pain, you can imagine what it takes to clean them, right? You got to move them, you clean them, move them back. There's no way that you're not going to leave bruises on the individual just by doing that because of all the other conditions, and just putting the physical discomfort for what, right? But I saw my mother-in-law's trust in this particular nurse, and she just held her hands and said, I trust you. Do what you need to do. And the nurse, even at that point, you know, she wanted consent. And the nurse said, well, what do you want me to do? Do you want me to, you know, take care of them and clean them? Do whatever you need to do. Okay. At this point, you're going to have to accept it as consent. You know, because it is, she's giving consent. So that, too, would not be paternalism. She's trusting that to the nurse. It may not have been the best case scenario, and the nurse even knew that. But at this point, it's not the nurse's call, right? She's an advocate for the patient. She's the proxy. She makes the call, so go ahead and clean it. He did pass away within the next 5 hours or so, and it wasn't necessary. Okay, that's all hindsight. That's not the point. The point is that the nurse was asking for consent the best you could possibly. It would not have been proper to say, in our experience, he's not going to survive the next 3 to 4 hours, because you just don't know. And this could go on for another week. You'd never know. So even though that's probably what was going to happen and did happen, you leave it at that. You accept the consent, and you do it, right? That type of thing. So even though it resides with the physician, you're going to find yourselves in positions like that. Unless there's a healthcare proxy or surrogate. Again, we're not going to talk about this in any length, only because we'll cover this when we do the end-of-life decisions. But this is really the best scenario, right? You have an individual there that is going to make determinations for them on their own. My mother, I remember her, my mother was so concerned that she didn't do something against the Catholic Church. That was her thing. Mom, she goes, Stevie, I want to make sure that we do everything that's right. Don't worry, Mom. We're fine, you know, that type of thing. But I was also there most of the time with her, so we were in constant conversation. That's your best case scenario. So they could waive this to a physician, or they could obviously waive it to a healthcare proxy or somebody with a medical power of attorney. Any questions on any of that? Okay. If you would, get out your phone. I'll read this, but remember, it's just Stephen Bueno 595, and you text that to 2 2s and 3 3s. So Stephen Bueno 595, and that shows up in the next slide. Okay, here's our scenario. These are all real scenarios. The names have been changed. I didn't change this name. The last class got a kick out of Johnny Avalon. Sounds like something from a beach movie, right? So Johnny Avalon, an 18-year-old living alone in San Diego, crashed while riding his motorcycle. He was traveling fairly slowly on a back street, but he wasn't wearing his helmet, which is remarkable, right? That you have to wear safety. You have to wear seatbelts when you drive a car, but you don't have to wear a helmet in Pennsylvania. That's a lobby right there. Anyway, he hit his head after being thrown from his motorcycle. He had no identification with them. In the emergency department, the decision was made to put Mr. Avalon on life support. But they found a hand-printed note on a small notepad paper was found in his pocket, and it said, "Don't keep me alive." Mr. Avalon was unconscious and he couldn't respond to any of the questions, but the team decided to go ahead and put him on life support. What do you think? No one consented to Mr. Avalon's treatment. Was it a violation of his consent? Yes or no? Okay, no is correct. Typically speaking, an emergency is an exception. Okay, but particularly in a case like this when there's nobody else there. The reason why I didn't just want to say an emergency is an exception overall is because if his father was there, the whole thing would have changed. Then the father would have said. But we don't have that situation. If a person is unconscious or alone in an emergency, consent's implicit. They will do life-saving techniques to save, well, life-saving techniques, leave it there. Now, they found this note in his pocket saying, "Don't keep me alive." The fact that they found that note, was that note itself a rejection of life-saving treatment? It does not say enough. It is problematic. And by the way, even if it were signed, I don't know if that would change anything. Do we know his signature? Do we have somebody to verify all this? I mean, you know, if you really want to assess this, think of yourself as a lawyer defending him. You know, there's no way that that would pass, okay? How about if he gains consciousness just before intubation and he asked to be allowed to die? Should they now stop treatment? Still no. Does anybody want to venture a guess? No? Why?
Because he was just in his head, like he could be concussed and not taken straight.
Got head trauma. You can't assume a person with a head trauma or in an accident, they might not be in shock. You can't just take their word. And just because they said that, go with it. Again, think like a lawyer. If you did this and it turns out the parents came at you, I mean, you'd probably be liable.
Would you also need like more information? Because what if he was suicidal? Wouldn't that like?
Oh, you know,
then
you're near genius.
say-
You are near genius. Hang on. I don't mean to stop you, but you couldn't have predicted it any better. Now suppose that Mr. Avalon carried the following typed and signed note. My name is Johnny Avalon. I intend to commit suicide today on a motorcycle. If I'm found after an incident, I reject all medical treatment. So let's say now you found that note. Is this what you meant?
Yeah.
Okay.
Well,
Well, you let me know if you want to, twist it around a little bit afterwards. So now what? Should the medical team discontinue treatment after that note is found? That's correct. You want to say anything about that? Or was anything?
well, I was just thinking, even if someone is like conscious and of age, if they're like not like mentally there, isn't their consent like?
It's questioned, yeah. Yeah, and by the way, this person was over 18. If it was under 18, they couldn't give consent, all right, without some legal guardian or parent. But here, the person just said that they wish to commit suicide. Now, this probably sounds like a very far-fetched scenario to you, right? I was listening to a radio podcast about a year and a half ago of a comedian, and I can't think of his name. I want to say Chris Rock, but it wasn't Chris Rock, but it was somebody who reminds me of him. So you would know him. And he, you know, a lot of times comedians suffer from the, you know, the sad clown, right? They're depressed. And he had said how he wanted to commit suicide. But you commit suicide, it wasn't Chris Rock, but it was somebody around that perimeter, right? You can imagine how then you seem to your family. They're all going to feel guilty. All the other stigmas that are involved in it. He couldn't bring himself to do it. So he had an idea. And what I found out through this is that this is not original. He thought what he would do is drive down the highway and just cut in front of the tractor trailer. And that way he's sure to die. The tractor trailer driver's probably not going to get hurt. And everybody will just wonder what happened. They'll never know that he wanted to commit suicide. So, you know, if this seems like this is a scenario that could never been possible, it could be the same thing. A guy goes on his motorcycle and just puts himself in a situation where this happens, okay? Any questions on this? Okay. Stay put for 1 second, then I'm going to let you